All right, we're right up at two, and I know that people have hard stops at 4. So I'm going to go ahead and get us started. And first and foremost, I want to thank you all. So I'm going to ask all participants to all of the members, participants, our guests, to put themselves on mute. If you have a question, if you have a recommendation, can you put that in the chat? Marcus on the CEG team is taking copious notes, and we will be compiling a list of recommendations. One of the most important things is that Dr. Birx sent me an email yesterday that she had to go to attend the last task force meeting today at 2. She believes that she'll be able to step out at 3:30. There's about and get on. She won't be able to get on Zoom because of security where she is, but she will hopefully be able to call in. We've given her a call-in number. So again, I want to thank everyone who is here, everyone who decided to join us, and everyone who decided to participate in this panel today. What we're talking about today is the COVID-19 preparedness in rural communities. And I want to, Marcus, can you go to the next slide? And so I want to first go back up. Yeah, so right here, so our panelists today are going to be Dr. Birx, Dena Hughes, who's the CEO of TAN Healthcare, which is in Beaumont, Texas. My newest best good friend, Dr. Clay Marsh of WVU, who is leading the West Virginia rollout, and Dr. Blanton Tolbert, not Talbert. Tolbert, please don't say Talbert when you ask him a question, because he'll yell at you like he did me. Okay, he didn't really yell at me. He just gave me a look and I knew what it meant. And so he's at the at Case Western. He's at in the Center for RNA Science, and he's going to help us a bit understand what is mRNA, what is, we're going to talk a bit about variations of COVID-19, South Africa version, Ohio version, Poughkeepsie version. We're going to talk about that a bit. What this product, what the 2 products are now, what does that mean? What's the Johnson & Johnson product, et cetera. So next slide. So I want to tell you that we have been doing these either in West Virginia specifically or across rural communities in America. And we have never ever gotten the level of traffic on our Facebook page or on any of our pages that we've gotten when we said that this was going to be the topic. Everything from it's fake on it to, you don't know what you're bargaining for. So this is just some of it. And I've even gone against my own rules about slides, and I'm actually using slides today. So I just want to say, I think that COVID-19 is one of those issues, is one of the many issues right now that has us not necessarily seeing eye to eye. But most importantly, next slide, Marcus, for me and to me is that 400, as of the time we made this slide, and I always I want to remind people of this, 408,687 Americans are dead. That's individuals that we know, that's our family members. This stuff impacts our friends, our families, our communities, and our nation. This conversation today is not about your political views or my political views. It is not about anything other than how do we prepare rural America to get ready to get vaccinated. And that's what we've got to do, because in order for us to fight COVID, to beat COVID, to win against COVID, we've got to get 70 to 80% of Americans to roll up their sleeve and say yes. Next slide. So what do I mean about preparedness? This isn't about the science of it, who did what to who when on Tuesday. This is about preparedness. We've got to educate what is a vaccine and what a vaccine isn't. That's why I've got Blanton here. I'm going to call him Dr. B because that's what I call him. I got Dr. B here to tell us what a vaccine is and what a vaccine isn't, right? We got a plan. What are our access points? How are we going to get this to people that have transportation issues and other issues? That's why I've got Dr. Marsh, because according to the Wall Street Journal, West Virginia's finally figured out how to do something right. And he's going to tell us how he did it, right? And then we've got to figure out together and make some recommendations to the new administration about how we're going to get people to buy into taking this vaccine. Because we've got to get COVID out of our lives if we want to get back to school, work, economics. We got to do it, and we got to do it together. And so I really think that we've got to think about this in terms of the stages of change, pre-contemplation. People already have made up their minds about what it is and what it isn't. We've got to help them. I don't see a lot of advertisement around helping people to understand what the vaccine is, helping people to understand its impact in their local communities and their local neighborhoods. Let's take it away from their mind. I don't need to affect anyone's mind with this. I've got to affect their heart. I've got to affect their heart. I've got to affect them that they don't want mama, grandmama, or the person down the street. So I got to get them through all of these stages. Next slide, Marcus. Here's a snapshot of rural America and why this is so critically important right now. Roughly 60 million people live in rural communities in the United States of America. We've seen 134 hospitals close, and that's since 2010. 21 of those hospitals closed in 2020, I think 2020, and 3 of those were in West Virginia, right? If we're gonna get to the end of this, we're gonna have to do it with some new and not just novel COVID, but we're gonna have some novel ideas. So I'm gonna stop right there, and I'm gonna take the moderator's privilege as I always do. And so, yeah, there you go. That's what we've got to do. How do we integrate COVID into everything that we are doing? Because it's a syndemic. Our local health departments, county health departments are already overrun, right? We've got to figure out how we're going to still address HIV, Hep C, viral hepatitis, obesity, heart disease while we're doing this. It's a yeoman's job. Hey, Blanton, I have a question for you. What is an mRNA vaccine? What does that even mean? And what does this even mean?
Okay, so Toni, thanks for the question. And first of all, I want to thank you for hosting this session today. I think it's very important. And I also want to congratulate Dr. Marsh for the impressive rollout of the vaccine in West Virginia. I was pleasantly surprised to learn about that in the Washington Post piece. So what is an mRNA vaccine? So the simplest way that I think I can go about describing this is that mRNA is one major class of biological molecules that make up all organisms. Okay, so everyone is very familiar with DNA, which is the genetic material, which is the material that our genes are stored in, that allows us to pass on our hereditary information. Then you have proteins, which you're very familiar with. That's another major biological molecule. Lipids and carbohydrates. Messenger RNA, if you will, is like a sibling to DNA. So it's
that's what sorry, Blant, that's what the M stands for, messenger.
Exactly. So mRNA stands for messenger RNA. And what that means is it's a copy of DNA. So it's carrying some information that's normally stored in DNA as a message in the form of mRNA. And that message gets read out by machinery within our cells to then make proteins. So the mRNA vaccine is a copy of the genetic material that encodes for the viral protein spike. Okay, and this is the protein that elicits the immune response. So the vaccine by Moderna, the vaccine by Pfizer is just a messenger RNA copy of that DNA that encodes for the spike protein. So once that messenger RNA is in,
So I hate to, you haven't been on these before, but the people that have been here before know this is how this party goes, Blanton. I'm sorry. But I have to like get you to explain this for the kids in the back of the room like me who really didn't pay attention in school, right?
Okay.
So you said a whole lot. You
All right.
said a whole lot. And so now, okay, so Moderna and Pfizer cooked up some DNA in a bathtub. And they said, we want to be able to send a message to the other cells to fight this COVID thing. Is that what happened?
No, so let's back up just a minute, right? So so the technology behind using mRNA as a vaccine has really been something that's been under the development in academic labs for decades. Academic labs like my own. We're specifically not working on an mRNA vaccine, but we work on RNA in general. So the technology behind this vaccine has been something that scientists like myself have really been focused on, as I said, for decades. I think, Toni, to get to your question, how is it that this particular mRNA technology was developed? Well, it's something that we can actually synthesize in laboratories, okay? And we can make these molecules under very controlled conditions, standardized conditions, right? And then test the molecule for efficacy and cell studies, and then in animal studies before they then move on to human trials. Okay, so is that a fairly good description, or do you
I'm
need
gonna
more?
say this. I'm gonna say I need you to talk to me like I'm two, right? Right, because now you done said a whole lot more, man. It's like now you said, okay, you got technology. So is this a computer generated thing? I mean, because I've got the HIV people on the call want to know how did we get a COVID vaccine so fast? We couldn't get an HIV vaccine. And so I think that's where some of the like confusion and mistrust comes from. You're saying technology. So now I got people thinking 5G radio waves, and see, I think that's how stuff like that happens. Right? So let's break this down.
Okay,
Right?
so when I say technology, what I'm referring to here is really sort of the basic science, research, and development. Not technology, as you mentioned, that would go into like a computer chip or into your cell phone, but this would actually be the laboratory-based technology by which we would synthesize and make these molecules and characterize them. You also mentioned HIV. We should also probably step back and just sort of mention viruses in general, right? There are many different types of viruses. HIV is a type of virus that's known as a retrovirus, okay? So retro meaning that it can actually go back in terms of the sequence of by which our genes are expressed, right? So DNA goes to mRNA, goes to protein, right? That's kind of the way the logic chain progresses. But HIV, being a retrovirus, has the ability of going back into DNA, okay? So it's a different challenge altogether, all right? Coronaviruses are a family of viruses that are referred to as RNA viruses. So their genetic material is stored in the form of RNA, okay? And these viruses behave differently than retroviruses. And I would say that they are less easier to vaccinate than HIV. But HIV poses challenges that we just have not experienced for coronaviruses.
And I think, I mean, it may be, again, because I'm the kid in the back of the room. I think that maybe one of those things that is that so HIV replicates very, very quickly, right? And so, but we're now hearing that COVID also has these variants, right? And so those variants are what?
Yeah. So again, sort of just stepping back. So I believe what you're referring to is that HIV and viruses in general mutate rapidly. Okay. So as an organism, viruses are very, very small, right? They are their genomes are tiny, okay? And as a result of having these small genomes, which is again how their genetic material is stored, they have the propensity to mutate rapidly. And I was thinking about a good analogy of this, and the best analogy that I could come up with before this Zoom. So because we're in the middle of the NFL playoff season, right? You can imagine that if a quarterback gets up to the offensive line and they're reading the defense and they see that the defense is presenting a different type of package, if you will, than what the play was called for. Then if the quarterback is smart, the quarterback will call an audible. We'll change the play. We'll adapt to what the defense is presenting. So you can take that analogy, if you will, and think about viruses. Viruses mutate rapidly. They change their genetic material because they're facing, right? They have to replicate inside of a host organism. Okay, so once that host starts to develop some type of defense or some type of potential immunity, the viruses start to call audibles, start to mutate rapidly. And that's just a part of their evolutionary design or their evolutionary history.
Right. Okay. I see that Dena from TAN has joined us as well, even though I introduced her earlier, but I'm not going to say anything to her about being late because I'm not that kind of person, because I would be a petty human being to do something like that. And that's not this party, right? So, all right, Blanton, I'm going to come back to you. Right now, I'm going to go over to Dr. Marsh because he had to figure out, and he apparently, according to NPR, Washington Post, Wall Street Journal, and many other learned journals, has figured out what it seems like many others have not. So, Dr. Marsh, how did West Virginia do something right in public health?
Okay, well, Toni, first of all, it's Clay.
Okay.
And second of all, it's not me, it's we, and it's big we. I think that there's 3 or 4 critical success factors. The first success factor, I think, is the simplest one, and the one that maybe many people on this Zoom call might sort of take for granted, but the ability to work together for a higher purpose and to commit each other. And, the Harry Truman, it's amazing what happens when you don't care who gets the credit, when you can have a small group of people that are really committed to facilitating and serving other folks, altruism, service, love, community. So that's what we've really seen in West Virginia. We were able to piece together a number of different people from different areas and different agencies, different sectors, and put them all together and act as a single team. There's a great book by Stan McChrystal called Team of Teams, and it really talks about his experience as the leader of the armed forces in the Middle East. And when he got there, he had the most sophisticated, most highly funded armed forces military apparatus in the history of the world, and he was getting his can kicked by people making improvised explosive devices off the internet and moving real quick. So he enabled the ability for his big team that was very slow to be much faster and more nimble. So first of all, we are working together as a team. Second of all, we used this opportunity like a military operation. So we formed a team called a JIATF, which is a Joint Interagency Task Force. And we have people from all sorts of different sectors, from the government, from Department of Health, Human Resources, from the National Guard, our medical people, hospital people, nursing home people, all working together. And then we did our prioritization scheme, which I think worked out well, which was really following the Advisory Committee on Immunization Practices from CDC, which is really our top 2 priorities were hospital workers, particularly hospital workers in ICUs, emergency departments, COVID units, and nursing home residents and nursing home staff. And it's important to note that 50% of all deaths in West Virginia happen from people that are in nursing homes. 77.5% of all deaths in West Virginia happen in people that are over 70 years old. And there's some outrageous data that I won't go into, but I may refer to later as time permits, from CDC that talks about the impact of age on mortality and hospitalization. So we really prioritize hospital healthcare workers, first responders, and then we got to teachers and other community workers, and then quickly also got to our over 80-year-old population, because that's the group of people that are dying frequently and going into hospital beds. And then we started our over 70-year-old population. So prioritizing the right groups. And then the last thing we did is we decided to maintain control over the vaccine coming into West Virginia. So there was a federal pharmacy program, and we met with Operation Warp Speed because we realized in our pharmacy network that about half of our pharmacies were independently owned. So if you look at CVS and Walgreens, it really didn't represent as much of a distribution across our state as maybe that those two businesses did across other states. So we worked with these pharmacies all throughout West Virginia with this joint interagency task force. And for instance, we were able to immediately work with our nursing home association. And before many states even got started vaccinating the nursing home population, we finished getting first vaccines in the arms of all of our nursing home residents before the new year happened. And we'll finish our second vaccine within a week or so. And of all the vaccines we've received, Toni, we've injected 99.6% of those vaccines so far. So we are leading the country. But the reason why we're doing it is because we know that every vaccine that we put in somebody's arm is perhaps saving that person's life. And so that's answering that higher calling. And I think it's really an example about what we've known the whole time. You know, there's an old joke, how do you know that you've broken down, your car's broken down in West Virginia? And the answer is because everybody stops. I mean, that's the kind of state we have. And I think the outside world is really just getting to see the incredible nature of our people. I mean, this is, you know, it's West Virginia may not have got all the great businesses and big metropolitan areas and airports and all that, but maybe we were getting saved for a time like now, because right now West Virginia is really shining, and it's because we can all sort of answer that higher calling and answer it together.
Thanks, Clay. And one of the things I keep thinking about is exactly that, right? Is that I think, you know, West Virginia is in the middle of also multiple or a syndemic, right? So we've got HIV, we've got viral hepatitis, we've got substance use disorder, and now COVID. So I think kind of my question for you, and I'm going to come back to you in a second, Blanton, because we have a question directly for you. But the question is, how do we ensure that these other issues don't fall by the wayside, and how do we work with the state and county health departments to ensure that they too are able to function and fully flourish? Because, you know, most of our health departments in this state are 3 to 5 people. We're not like big city health departments, you know, and so now we're asking them to deal with COVID. Substance use disorder isn't ending. We've got higher rates of overdose happening at the same time. So, and I see Rustin sitting there. He's like, "You darn right we do." And he didn't say it, but I said it for him. And and so, you know, how do we do that? And the final piece of that is, I also understand you're getting hit over the head because you didn't vaccinate the medical students. Do you want to talk about that? Or
Yes,
no?
sure, of course. So that was a lot of question there, Toni. So let me.
This is my job. I don't come tell you how to do your job. Don't come tell me how to do my job.
I'm going to unpack what you just said. So let me just say, I think that there's a really important point that is really implied by your question, but maybe not as obvious to some other people. So to people on the phone, know about the Adverse Childhood Experience study from the Kaiser Family Foundation,
Probably not.
or the work of Sir Angus Deaton and Ann Case at Princeton. So let me tell you about this, because when we talk about public health in West Virginia, I think we are starting to build the infrastructure for a much brighter future right now. And there's a lot of pressure on a lot of people. So let me tell you about these two studies that I think are just absolutely mind-blowing, and many people don't know about. So the first study is a study in 18-year-olds and younger, and it's called the Adverse Childhood Experience Survey. And it's a 10-question test that was generated by the Kaiser Family Foundation that was given to about 17,000 kids. And it asked about 3 issues: about trauma, family dysfunction, and so trauma, family dysfunction, and I'm blocking on the third one, but I'll think of it. And basically, so questions: were you loved when you were a kid? Did you grow up in a safe place? Did you live with your parents? Did your parents ever get put in jail? Did you ever get threatened by violence or sexually inappropriate behavior? The average score in America is 1, and a score of 1, this is 18 and under, your lifetime risk of heart disease, diabetes, obesity, suicide goes up, okay? If your answer is 4, and we had a small harm reduction clinic study in Charleston, which the score was 4. If your score is 4, your risk of chronic lung disease 600 times or 600% higher than if your answer is 0. Your risk of suicide overdose 1,200% higher, and your life expectancy predictably 4.7 years less. If your answer is 6, and J.D. Vance and Hillbilly Elegy had a score of 7. If your answer is 6, your lifespan is predictably 20 years less than if your answer is 0. This is your lifespan. And if you look at the worst county lifespan in West Virginia, which I think is McDowell County, at least it used to be, and the best county in the country, which is in Colorado, 20-year life expectancy difference in those two places. So the impact of traumas, of not feeling loved, of not feeling safe, of not feeling worthy, of feeling isolated, scarcity, is really, really a problem for your health. And this really kind of dovetails into work that Angus Deaton, who won the Nobel Prize for Economics in like 2000, whatever, 7, 8, and his wife, Ann Case, and they were doing work and looking at people who were whites, non-Hispanic whites, high school education less, and they were looking at their economics, and they found this incredible sort of finding that they were dying young. I mean, the mortality rate in this group was like the peak of the AIDS epidemic. I mean, it was really crazy. And they did the review, the work, and initially said, well, they're dying of liver disease and overdose and suicide, really addiction-related problems. And they got deeper and they said they're really dying of hopelessness and social isolation. They didn't feel like they were worthy. And when you look at the Gallup Index, which is a 5-area question about health, perception of health, financial health, physical health, social health, friends, living in a good, safe place, and spiritual health, West Virginia rates last in the country for like the last 8 years. It's our perception of our own health. And so I think when we look at public health and we look at these problems that we're seeing, and this may be not including COVID-19, but I think what you're seeing is a lot of these problems are problems in our own narrative and our own mindset. And if you basically don't believe you deserve to be healthy, well, you can't see it to be possible. You live in the outside world, disease, dis-ease. So if your whole life is like you're small and getting restricted, then I think that's the way that you live. On the other hand, if you feel like that, you are a powerful creator and you're able to generate the life that you deserve and believe, as we all are, right? Namaste, which translates into the divine in me recognizes the divine in you, all part of the same thing. The root word of health, Toni, is HAL, H-A-L, which is also the root word of health, heal, holy, holistic, and it means whole, W-H-O-L-E, complete, part of the same thing. And so I think this idea about seeing ourselves part of a bigger whole, which is what's happened during the COVID pandemic, I think is the foundation work that we need to do to really help West Virginia rise and help our, our own citizens start to gain that narrative that the outside world is starting to say about us. And as we go, of course, we need to fund more heavily our local health departments and county health officers, build our infrastructure, which is not just more hospitals and clinics, but it's more community services, more caring, more love, more safety. Project Aristotle by Google looked at their best performing teams, and they found the biggest thing that was different about the best performing teams, not happiest, best performing, was high degrees of psychological safety on their best performing teams. Maslow's hierarchy, physiology, safety, love, self-esteem, self-actualization. So I think the answer to public health, the answer to population health, is changing the narrative from one that is scarcity oriented and based to one that's abundance based and sees possibilities like children. And I think that's really the transformation that's starting. I think our governor's doing a great job because the brand is not just what people of the outside world are saying about us. It's what we're saying about ourselves that makes the biggest difference.
Thanks, Clay. Because it's funny that you say that you brought up ACEs because I didn't see you going that direction. But that's one of the things that I just wrote a proposal saying that we needed to include the ACEs Coalition, West Virginia Primary Care Association, and the CBOs in those states, any community-based organization in those counties, to work with ACEs. Because Dr. Brumage really did a lot of work to bring ACEs into West Virginia, but I think we also need to look at other rural communities rolling out ACEs. And before I forget, I'm not going to let you off the hook about those med students either. I'll come back to you on. I'll come back to you on that.
I can answer that.
But Blanton, here's the question. Are the variants that have been seen so far simply indicators of viral drift, or are we in danger that we could be in an actual viral shift as what happens with influenza?
All right, so to answer that question, I think I'll start with attempting to answer the second half of the question. I think this goes to the importance of getting the vaccines out and widely distributed such that we can generate a level of immunity in the population to, in many ways, offset the numbers of variants that we see now that are starting to circulate in the population. So to answer the first question, this concept of viral drift, and it goes back to really what I was attempting to explain earlier. Viruses mutate rapidly. Okay, this is just a part of their replication cycles. Okay, their quote unquote life cycles inside cells, if you will. One of the key areas with which we see an increased number of mutations are within that spike protein. Okay, and why is that? That spike protein that's on the outside of the viral particle is the actual protein that makes an interaction with the cell that's infected. Okay, and so it's to the advantage of the virus, right, and to be able to increase, if you will, the affinity and the avidity with which that interaction takes place, because the virus needs to enter inside the cell in order to complete its replication cycle or the life cycle. Okay, so there will be this natural tendency in viral evolution for mutations to populate in certain places across the genome of those viruses. Some of those mutations will be selected for, meaning that they will be favorable for the virus to replicate. And some examples are these UK variants that we see now, the South American variants. Others will be deleterious for the virus. But because the virus can mutate and replicate rapidly, it's able to overcome some of the deleterious mutations and then select for the mutations that will give it an advantage to like infecting cells. So hopefully that was a good explanation.
Now I'm going to go back to your very own analogy, all right? For the slow kids like me in the room, right? And because I'm assuming I'm not the only slow kid in the room, but this could be the fact and this could be the case. So I'll make sure I understand. All right, I'm COVID. I come up to the line. I'm in the pocket. I look at the defensive line. I'm looking at the defensive line, but they just shifted. They did a shift. And now it's not the same COVID. They shifted one more time, and now that's the South African variant. And then I hear the captain on the defense, I'm still COVID, I'm still on offense, right? And then I hear them do another call that they doing, and they shift again. That might be the Ohio variant that just popped up. But I'm still COVID, and I still am what I got to change what I do because they're changing what they do. Is that what you're saying?
Well, so in that the analogy that I attempted to give, I would say that in that case, the quarterback would be the virus, right?
Okay.
And the defense, in many ways, would you could consider to be the cells in which the virus is going to infect, right? And so the virus has to be able to compete and to survive. And so the analogy then would be that the quarterback going up and reading the defense has the ability to call an audible to change the play to get around a particular type of defensive maneuver that might be presented.
So actually okay, so what you're saying is actually the South Africa variant, the Ohio variant are actually my front line, and they're the ones that's changing, and I got to listen to the COVID, which is over there.
No, I'm saying that those are the audibles.
Okay.
I'm saying that the South African variant, the UK variant would be the audible. It would be the mutation that has been selected for now to perhaps give the virus, as we believe we know about the UK variant, it transmits, it spreads faster. And in part, it spreads faster because of the way it interacts with the receptor on the outside of the cells.
Okay, so I go back in the pocket and I say, I done held this ball too long, right? Because I heard all of this now.
And you change the play, you audible out to give yourself now an advantage over the new defense that you're being presented with.
Exactly. Okay. But for those of you who are not football people, I'm sorry for that. For those of you who are football people, I hope you got that because it made sense to me. Clay, I was going to call you Dr. Marsh.
That's good. Let me make one additional comment if I can. So if you think the defense is the monoclonal antibody from Lilly and the offense is COVID, then the defense is neutralizing the offense. And these variants are the ability of the offense to get away from the defense.
Okay, there we go. So now I'm going to bring in Dena because if not, she'll lose interest in this whole process. And I know
I'm sitting here like, I wish I knew football. Oh my God, but I get it. We're good.
Right. So Dena runs TAN down in Beaumont, Texas. And I really wanted to have Dena on for two reasons. One of the questions that we actually got was from somebody in Texas when we promoted that we were doing this. It said, there's a vaccine void in the Golden Triangle community of Southeast Texas. These three counties, Jefferson, Hardin, and Orange, have 366,000 adults who will require 2 doses of this vaccine. If we are to build herd immunity, we should consider vaccinating the first available so that we can make up the time lost vaccinating tiers 1 and tiers 2. So I wanted Dena to kind of talk to us about FQHC's roles in rolling it out, availability of vaccine, because then I'm going to talk, I want Dr. Marsh to talk about how it is that West Virginia said, no, we're not going with your plan. We're going to do something else. And then I want to talk about a couple of recommendations and ideas in a minute. Go ahead.
Well,
Dena.
thanks, Toni, for the invitation. And I just wanted to introduce Amber David. Amber is our community engagement coordinator here in Beaumont, but he has a dual role in that he also works in Houston with totally different facets. And so a lot of what we're trying to do through him is connect rural and larger cities and see what we can do similar and what we can, what has to be different to move this ball along. So I invited him just to sit in case he had some insight from what he sees going out into the rural area. So we are an FQHC. We have 2 locations, one in Beaumont, one in Orange. There are actually 3 FQHCs in a 6 or 7 county area. And so we all, of course, as FQHCs have similar responsibilities, but implementation tends to change depending on your population, where you're serving, what's coming in your door. So we were very much on the front lines of testing. We learned, let me just back up. We learned during Harvey that FQHCs are not first responders. We're not here, first responders. We have that, we have emergency management, but we are and recognize our role in the aftermath. We're second, third level, ready to be there for that consistency when those challenges occur. Same thing happened during COVID. We became that testing entity and involved ourselves very heavily in community testing for a couple of reasons. One, for me, and I'm a Houstonian by kind of raising, so I'm used to kind of the bigger city models, participating in HIV mass testing events. I was very surprised to find very limited coordination in terms of a 7-county area that pretty much we all work and live. It's about a 2-hour drive in every direction, so it's manageable. You can move around. And so between living and working, there's a lot of commonalities, but when it comes to developing a structure that is uniform and address the needs of such an area, then you get back into individual counties, and then you have to hope all county judges agree and all commissioners agree. And it's a very convoluted dance. And then it really becomes a compromise of whatever year you're in, because it has to be a myriad of considerations in trying to roll out something. Testing was definitely a challenge. And again, Amber joined us mid-year last year to really help move conversation in communities in rural areas that were underserved, including African-American and Hispanic communities, because quiet as is kept, they're there. And so we wanted to make sure we did things and promoted activities and events that encouraged communities of color to get tested, even if we were going up into more rural areas. But again, coordination lasted a very short time. I think 5 counties, and I see Cordella is on the call as well, and she's with us in Beaumont, so she could probably speak to some of how that worked. And I bring it all up just to reference what I see coming for vaccine, and that is nothing changing. And that's kind of sad, because again, we'll get into the rhythm of we want to do it this way, we want to do it this way, let's do it over here instead of over there, who gets it, who distributes it. And my biggest challenge that I have with this entire system is that the public health entities are not actually at the forefront of the conversation. The forefront conversation is our county judges, our county commissioners, and our that community. So once they make the decision, and you also have the county judge and the county and the city mayor, and they're so close, everybody's so close that, that's where a lot of the power is left. But when it comes to making decisions about the public health of that entire region, our public health entities, I personally believe, are second tier to the conversation and not first tier, which prohibits a lot of the use of resources, use of skill and talent, use of excess and additional support that could make something more sustainable, even if you did mass events or individual testing, they're not included at the table. And that causes, the rest of us, and I'm grateful as an FQHC in this dance that we're a member of a membership organization, which, FQHCs, I think every state has the community health center memberships that provide us with guidance in terms of what FQHCs are doing. So I take that information to emergency management or to commissioner's court or to the judge or to the mayor of all 5 of these towns, trying to have a conversation about, hey, how can we help? What do you need? What are we doing? And so it's convoluted from my perspective. And again, I think coordination is lacking because we do have hospitals that are also involved and invested in the community. But I have one whole county that has no hospital, no emergency room, no nothing. So another county has to run that county's activity, but yet public health isn't integral in these conversations. So, I'm thankful for the invitation to come and listen and see what other communities are doing, because from a regional standpoint, we are trying to figure out what makes more sense for us to do and how we can do it. And again, the city of Houston is an hour and a half away from us, not that far, for us to be able to have conversations with them and try to follow some of the techniques. But if you're not at the table, then you can have the best techniques in the world or the best ideas in the world or things that could be really helpful. But if you're not at the table, then that comes on the back end, which we experience quite a bit, which sounds like, hey, are y'all testing? We need to and now it's a crisis because you didn't have all the right partners at the table to pick up their part and be ready to dance when you were in that planning phase. And so I'm looking for recommendations and ideas and suggestions that could help move us in our state, in our region, toward more efficiency, because we recognize that neither testing nor vaccinations are going to be going away anytime soon. Uh-oh, I don't hear her. Why don't I hear
you hit on a couple of what I think are critically important points. So first of all, I want to thank you for being here. I want to thank you and Amber for all you do in Beaumont. But am I wrong in that Houston just had a big vaccination, come get vaccination event, and so there's a billion people, right? Yeah, I don't know how many people live in.
He can tell you all about it. Yeah.
Yes. And what? What's the question, Toni?
The question, here's my question, and it's a bit for Clay, because I think that I think that the way Clay did this, which is said, no, we're going to centralize this and we'll run it from here, rather than this county by county approach, which I call in West Virginia the home rule approach. Because if you do it with this home rule approach, it's county by county approach, you got to then deal with the county commissioner, you got to deal with that chief, you got to deal with that health department and that mayor. But the way it sounds like Clay did it is that he said, whoa, everybody back up. We're going to centralize this. We got this. And so those partners then become health departments, FQHCs, hospitals, and pharmacies. But I think that I wonder, can you do that in Beaumont? Can you say we're going to centralize it through either to have Houston say, we'll help you out, or something? I don't know. Clay, I don't know what I'm saying.
Toni, part of the I think the challenge is it takes somebody with authority to say, hey, wait, right? When the public health departments are in the room, they're, and again, I'm speaking from what I see, what I know, but there's a sidelining, right? One of the conversations that I learned, because we were talking, they're definitely talking about what to do and how to do. But one of the concepts is using one of the hospitals to be the recipient. And it's like, okay, that's cool. You can receive the vaccines and we can do that. But when it comes to data entry, she tells me, well, we have to enter this data twice. Well, nobody has two staff loads of data in data managers or data entry staff to be able to do that. And so you have to use, your outside partners. Well, then you get in, because this is still anti-masker kind of scenario out here as well. So now we get into privacy. Who got my information? What you doing for my information? Why are you putting it in and it's going over there? So, I mean, there's a lot of different dance dynamics, but what's crazy is we have hurricanes here every year, like clockwork. And you would think coordination at a more substantial level would have taken place to be able to address issues like this that come up, or at least have a structure. But right now, if you don't have a phone and that person's phone number in your phone and it's their personal cell phone number, and there's a meeting coming up and you happen to call, you're gonna miss that. But you'll get a phone call in a crisis. And that's just not the way to, I personally would like to function for the next 2 years. So we're looking at ways of working together. Lamar University is here. They have a nursing program, so they're very involved. Baptist Hospital, Christus Hospital. We have folks at the table, but how many tables do we have, and what time are they meeting, and who all invited? Those are some of the critical questions that I think community health centers, FQHCs, ASOs are left out of.
Toni, and I wanted to say that when we go, so I basically head up her mobile testing team. So we're always always ready to go out to do what we need to do in communities. And I really mean plural. And those are different cultures from 2 miles apart. We have to try to educate community around the science of everything, one way in 2 miles and another way in another 2 miles. And then some people drive 20 miles to come to one site, and those cultures kind of clash. And we have to try to educate with the science of if it vaccine or testing. And part of our work is to create trust when we show up to buy in to the science. So that's what we find happening with us going out. We'll go east and have to do one thing, west and go another, and no trust behind with the government one place. So every day, our team needs to really be the same team, because we have to adapt. Community person by community person, to sell them on the health of their community for them to buy in.
Well, you come to, Amber, exactly what the whole point of this call is, right? Is what are we gonna do to prepare rural communities to roll up their sleeve, right? Because in order for us to knock COVID in the teeth, we've got to vaccinate 70% of the US population. And we got 60 million people that are living in rural communities. And so we got a tough job ahead. We don't, not just a system that's working like Clay's, or not just the basic science like Blanton just gave us, or not having the facility. We've got to prepare people to do it. So, and I don't think it's just political. I think we also keep missing a step, right? We keep saying, well, now, okay, COVID is a problem. Now you might have some people that say COVID not a problem. It's a hoax, right? Okay, guess what? If it isn't, not the monkey I'm trying to fight today. The reality is that 408,000 people are dead. Whatever it is, I don't want another 408,000 people dead. That's all.
And one of the things that we're looking at doing is normalizing both COVID screening and, hopefully down the line, normalizing vaccinations. And you know me, Toni, I'll ask a question and it could be a profound and deep thought, or it could be I'm the only one that doesn't know the answer. But I am asking the question now, if you're coming in for an HIV screen, which we love and do here, or a Hep C screen, or, a flu, or a strep, COVID should be right there with, we're going to do them all. We're going to do everything we got. We're going to do everything. So we're looking at how do we normalize COVID in an environment where there is, disbelief that it exists. But if the only thing you do is pop up an event and then pull it down and then pop it up and then put it down, you're not creating a consistent rhythm of conversation. But if I can get you, when you come in, you hadn't thought about it, it's not a part of what you're doing, like you said, but HIV isn't either. But we still say, we're going to run through all of these real quick on you, make sure we're all kind of good, send you back out into the world. COVID should be a part of that so we can normalize it and not allow it to get to a place of stigma. We're out here, it could very easily become, it could become stigmatized, stigmatizable, whatever.
Clay, you unmuted yourself, so it looks like you're ready to jump in.
Yeah, I have a couple of things that I want to add if I can. So number one is I think that ironically, this rollout is much easier in lower populated, more rural states than it is really, really, high populated states, because getting all the stakeholders in the same room on the same page is virtually impossible. And I think that that's what you're commenting about. And so I think that it's a much tougher nut to crack in Texas and New York and California in some ways. The other thing I just wanted to address, which I think is really important too, is with the vaccine rollout, you can't vaccinate everybody all at once. So I would also want to point out that the prioritization of what you do and how you do it becomes really, really important. And let me just quote this data from the CDC. It's from August. And I would be willing to bet that most of you guys haven't heard this yet. It is mind-blowing to me, this data, okay? So if you look at 18 to 29-year-olds, which is our healthiest population, quote unquote, and you start to look at people that are older, and you look at risk of dying from COVID-19 and hospitalization, okay? Mm-hmm. So if you compare 18 to 29-year-olds to 50 to 65-year-olds, 50 to 65-year-olds have a 30 times risk of death and a 4 times risk of hospitalization. If you go 65 to 75-year-olds, 65 to 75-year-olds have a 90 times risk of death, 5 times risk of hospitalization versus 18 to 29-year-olds. 75 to 85-year-olds have a 220 times risk of death and an 8 times risk of hospitalization. And over 85-year-olds have a 630 times risk of death and a 13 times risk of hospitalization. So as a state, and Deborah Birx would say this to you if she was on this call right now, if you're not looking at your older population, you're missing a massive opportunity, because we worry about surging in the hospitals and the increased mortality that not only comes from COVID, but comes from heart attacks and strokes, et cetera. And so we have really focused, and this is the governor's doing, but we've also really encouraged this, that that's the reason why we went so quickly to our nursing home population and try to get vaccines in the arms. Because, it's interesting that the ACIP, the group, the Advisory Committee for Immunization Practices, when they voted, and they voted about nursing home residents being the top tier, the one person that voted against it is our nation's expert on vaccines in the elderly, apparently, or an expert, because the clinical trial didn't include these patients. So we don't really know, do all the nursing home residents actually get the benefit? But what we do know is this is a group of people across the world, across our country, across our state, that account for over half the deaths from COVID-19. So as we are aggressively immunizing this population and then doing the research to say, does it really work on this population? We know that by immunizing the folks that are likely to die or be hospitalized, have the most severe illness, then we protect the hospitals, we reduce the death rates. So I think that for all of us, we should really get very clear about what our intention is, what our strategy is, what our priority is, because that makes a huge difference. And if you can only immunize so many people, then immunize the people that you think have the greatest benefit of the immunization. And I'm not saying that I know for every state, but that is our logic. And if you look at the UK, they started their whole country, over 90 was the first group. Over 80 was the next group. Over 70 was the next group. They had nothing to do with hospital workers or healthcare. And Toni, I want to get back to your question about the medical students, because I think this is really important. And this is important about the schools as well. So when you look at the data, at least when we started the COVID pandemic, and it makes great sense, that we thought that the severity of the secondary transmission in communities really defined the transmission in hospitals and healthcare settings and in classrooms, et cetera. But since we've gone through it, what we figured out is if people really are good about wearing masks, and about 90% of people wear masks around each other and physically distance, the transmission rate of COVID-19 goes down to like everybody's had a vaccine. It's really effective. And that's because obviously COVID spreads by aerosols or droplets and spreads a lot by people that don't know they have the infection. Half to 3/4 of infection spread is by people in the pre-symptomatic or the asymptomatic period. But if you look at household transmission, people that you know have COVID in the same household with other people, you might say the transmission rate's got to be out of this world, so high. In China, they were 19%, and the US, a recent study, 35%. So most people aren't going to get COVID. And if you look at COVID, people infected, 70% of people infected with COVID will not infect a single other person. And about 10 to 20% of people infected with COVID will infect 80% of other people. Those are the super spreaders. And that's a reason why testing people is important, and asymptomatic people, because these are people that can spread it. And if you look at the transmission rates, if COVID's 2 to 2.5, the R naught level, the reproduction rate, and you look at 10 doubling times, which is about, doubling times about 6 days. So 10 doubling times is about 2 months. And so if you have somebody with COVID-19, and I'm going to talk about the mutants just for a second, and then I'm going to finish. So if you look at the R naught level of 2, meaning one person on average infects 2 more people, and they infect 2 more people, and they infect 2 more people. In 2 months, that one person will have infected 1,024 new people, okay, if you don't interrupt that chain. In 2 more months, because of this effect of compounding, this logarithmic effect, that one person, 4 months from the beginning, will have infected 1 million new people. And 2 more months from that, 6 months total, that one person will have infected 1 billion new people. So ultimately, these networks start to go. And the problem with the mutant strains is the R naught level is not 2, it's probably more like 3 to 3.5. And that compounding effect means that it goes much faster. So this spread really goes like compounding your money. You know, put your money away when you're young, because the compounding benefit gives you a lot more money at the end than if you try to sock away a whole bunch of money when you get older. And when you look at the spread in these protected environments, heavily mitigated environments, whether it's a classroom or a hospital room, then the spread from a patient infected or a kid infected to a healthcare worker in that environment or to a teacher is really low. Study in North Carolina schools said for a whole year, they didn't find a single case of a kid spreading to a teacher in a classroom. And so the spread happens from people that are infected in their homes or communities that come into the school and then play on a sports team together where nobody's wearing a mask, or have lunch together, or have a lesson planning thing together, or sit in a school bus, you know, talking around the buses together without masks. But in the classroom, we see very little spread, and we see very little secondary spread in West Virginia. That's the reason why we're changing this year to starting in-class school, because we see that the transmission rate in the classroom, and that's why we didn't immunize all the medical students to begin with, the transmission rate in a protected environment where we're screening people for COVID and not letting our students take care of COVID patients or people under investigation for COVID, and them wearing the appropriate face mask. We have not documented a single case of spread between a patient and a student, but we are starting, but we want to vaccinate them, but on a priority basis, we've prioritized our elderly, as we've talked about, and now we're getting additional vaccine. We're starting to immunize our students through our Higher Education Policy Commission, because we also want to protect them, but we want them to be able to be part of our vaccination teams and other things going forward, so that we can reach more West Virginians, hopefully, as we get more vaccine coming in.
So, all right, you used a lot of words to say that you decided, you looked at the data, not the issue, you decided you were walking down the street and made a decision, but that you actually looked at some data and you read a couple of articles and you looked at some trend data and you decided, listen, there's a limited amount of juice, right? There's a limited amount of juice that we have. We have to prioritize who gets the juice. And if we look at the data, these students are less likely to transmit or get infected with COVID if they do these other things, right? And they stay in this space. So we're going to use our juice, our limited resource. You know, if we're talking in community resiliency models, our limited resource, and we're going to vaccinate our elderly population who's more likely to die, get in a hospitalization and die. And so we don't want that. So we're going to prioritize this other population. Is that a very oversimplification of what you said?
Yeah, that's exactly right. And also that the fact that, you know, we want to immunize everybody in our state, but we have to go about that in a logical, hierarchical risk model. As you said, it's important. So I would just say one last thing. And we also have elected to immunize a lot of our critical workers over 50 years old. And the reason why is because if you look at the deaths in West Virginia, and we've had over 1,800 deaths now in West Virginia, 97% of the people that have died have been over 50 years old. 92% of the people that have died have been over 60 years old. 77.5% of the people that have died have been over 70 years old. And 50% of people have died have been residents of nursing homes. So when we pick our money shot and decide to target our resources, that's how we did it. And it's not me that decided, it's the governor, but we've made a lot of recommendations to the governor.
Speaking of recommendations, I'm glad you used that word. That a part of the goal with having Dr. Birx on and hopefully having all of you on and having community on is, again, I go back to, we want to talk about vaccine preparedness, because I think Clay, great model, great press, great media, but now I've got to get the rest of rural America, right, to come up with a model program, right, so that we're getting people vaccinated. And so, and one of the things I'm not seeing, and somebody actually asked this question, but it's also my question, it's like, what's the messaging to prepare people to come in? Where's the information to say, this is the frontline defense quarterback vaccine coming to you real soon, right? Coming to an Omni. This is where is our vaccine? What is our vaccine preparedness strategies? And so let me read a couple of the questions, and this will be for all of us to discuss. What is your messaging strategy, like when to go into these communities? Do you have recommendations on how to communicate effectively with not just rural residents, but rural people living with HIV? What about the efficacy of the vaccine for those living with HIV? Any results, information on any clinical trials showing that? And then I know, like I said, my goal is that we would be able to ask Dr. Birx some of the questions, but also have, I know that they're probably having the last task force meeting as we speak, but is there a way to get this information to the Biden administration? The president-elect mentioned rural communities as a priority in one of his recent speeches, but I'd like for us today, and I mean today, live, real time, to come up with some recommendations of what's needed in rural communities. It's like, Dena, I think you talked about, is, are these hub models working? Is this what's needed? But also, where's the social marketing and media? I mean, I think I read somewhere that there was a $300 million campaign. Where is it to tell us here, to educate the community? If you don't roll up your sleeve, COVID's gonna stay here. And that's what the campaign needs to be. If you don't wear your mask, COVID's gonna stay here. If you get the vaccine and don't wear your mask, COVID's gonna stay here. We need a campaign that's out in the field. And I don't know if Ronnie's on the call, because I know Ronnie at one point was doing some work on these messaging, but we've got to have a plan for the message, but we've also got to have a plan for where and how we access people, because all these people are not going to come into the Houston, what's the name of that Houston arena? Because y'all got like 15 million corporate sponsors.
We did Minute Maid this weekend. We did 6,400.
6,400, right? So how do we get that in rural America, given transportation challenges, broadband challenges? So we've got a whole bunch of things. Marcus, so I want us to answer the communication questions and have a conversation about it. And also, Blanton, somebody asked the question was whether or not, what do we know about the J&J product? What do we know about future vaccines that are coming out that are one dose? And I think everybody has the question of how long does this vaccine actually last? I think all indicators are Moderna, I know, is saying 1 year, and that's what they'll say. And it's going to work on the variants. But again, I want to come back to how are we implementing a vaccine preparedness plan? And so I have a plan, Dr. Marsh. And I'm going to come up with my plan, and you're going to think I'm crazy. But here it is. Dollar General, right? Believe it or not, there are 16,720 Dollar Generals in 46 states. If we did pop-ups at the Dollar Generals model says that you should be in your car a 5 to 10 minute drive from a Dollar General. They're all over the United States, except you see that little section there, and I think we can look there for Dollar Tree and Family Dollar. You guys think I'm crazy, but I really started thinking about this. It's where they have in the Dollar General stores, they've got refrigerators, they've got coolers in there. So if you needed to cool down something, and a 202, I don't know, we have a 202 number that just entered. If that's Dr. Birx, let us know. Okay, Marcus, go to how many of them are in
Hi, Toni, it's Debbie.
Hey, Debbie, how are you?
I am terrific.
We're coming up with recommendations, and I've just suggested that we do COVID testing at Dollar Generals across the United States. Marcus will make sure that you get all the slides. So here we go. Over 70% of Dollar General customers are women. Roughly 35% of Dollar General shoppers have an average household income of less than $25,000 annually, while 28% have an average household income between $25,000 and $49,000, right? Their population is 45 to 64. That's that next big band that we need to reach. Dr. Marsh, play, next slide. Dollar General has 16,000 stores. Dollar Tree has 15,000. McDonald's has 13,000. CVS, 9,600. Walgreens, 9,000. Family Dollar, 7,000. And Walmart, 4,700. If we use my Dollar Tree model and either work with local community health departments, work with the Army Reserve and with the National Guard that you've also been using, but that's more than the pharmacies. That's more than retail pharmacies that we have, because we looked at big box pharmacies. Go to the next slide, Marcus. And that's how many Dollar Generals are in West Virginia. Tell me why my Dollar General plan is crazy, Dr. Marsh.
No, it's not crazy at all. From a vaccine distribution standpoint, our limiting factor right now is number of vaccines. So we have the infrastructure to, we think, to more than quintuple the number of vaccines we're getting weekly to put in people's arms. So we believe right now we get about 23,600 vaccines a week, and we think that we could deal with about 125,000 a week. And in that way, we would be able to vaccinate more. But I think your model, Toni, of looking at how we can push these assets closer to where people live and make them more, more accessible is really important. But I also think that, at least what I've learned, and certainly Dr. Birx, now that she's on the call, can make some much smarter comments than me. But we have to be careful about not asking businesses to become what they're not. And so part of the challenge I think that we've seen is, as we've worked with a lot of retail pharmacies, we want them to push vaccines out. We decided early that they needed to be the command chain for the vaccine, because they were the people that were the most qualified, pharmacists, pharmacies. And so when we distributed from our hubs the vaccines, they always go to pharmacists. That's who takes care of them. But when you look at retail pharmacies being really big vaccine places, that started to fall down some, because that's not what they do. They have other parts of their business. They, have other prescriptions. They take care of people in the community. So we are starting to relook, and the same, including local health departments. Some local health departments are really small and overwhelmed with other stuff. So they're not the places that are going to be able to push out tremendous numbers of vaccines, because it just overwhelms their workforce. And that doesn't mean that the communities shouldn't be, given the vaccine, or that the county health officer shouldn't have a critical part in that. But it's really learning your own systems. And the only way you do that, I like Eric Ries's lean startup model, which basically is kind of like the complex system, the marine model, which is 70% likely have a solution. You implement the solution and you measure the outcome, and you either continue, you change, or you kill it and you do something different. And this is really a rapid cycle learning model. And that's why I talked about the team of teams in the McChrystal book. And I think that if you don't have your hands on this and you're not really learning, getting data back all the time, then you're not really optimizing your system. And every state or every county or every region is going to have some unique features to their system. Dollar Generals are an asset that can be leveraged, but whether or not that's the right way to leverage it, I think that you have to start to implement through that pathway, those assets, and see what happens. And maybe some Dollar Generals are perfect solutions in certain communities, and maybe in other communities, the Dollar Generals aren't at all, but you don't know until you really start. And I love, the Goethe quote, whatever you believe you do or plan to do or dream you can do, start it, because there's a power and a magic to the boldness of just beginning. And I think a lot of places are just paralyzed waiting, and we've just been trying, and then getting that input back again.
And so, I guess we just acknowledged that Dr. Birx has joined us. Dr. Birx, thank you so much. And I just think that I've come up with the most ingenious idea, and Clay has just shut my idea all the way down. But don't worry, it's still going to be on our recommendations list. Thank you for joining us this afternoon. Can you maybe talk to us a bit about what you know about vaccine preparedness, educating the community, messaging? Because we were talking earlier about what we've got to do is not attached to people's political views or their intellect, but we've got to get them to their heart so that they understand this is their challenge, individual challenge, family, community, and a nation. And then we've got to do this together. And that that's the only way that we get 70 to 80% of Americans inoculated. What do we do for messaging to prepare communities?
Well, thank you, and it's such a privilege to be with you all, and I apologize that I missed the beginning. There was a task force meeting called at the White House, and I'm still in the White House. Not many people left, but I just really wanted to get on this call. It was really important to me. I have really being able to be in the United States and out in rural America and being able to listen to people and understand and hear from them about their unique needs. And I think what was encouraging to me about this Dollar General idea, and I'm just going to be frank, what we're asking people to do in order, there's a lot of people out there who want a vaccine. But we're asking 80-year-olds to be able to register on IT sites that are completely foreign to them. I've been trying to get my parents vaccinated that are 92 and 96, and this constant refreshing of sites. How Dollar General could be amazing is really having volunteers there to help people, just like you would do register to vote. We need people to be able to register for vaccines, and then someone help them, walk them through how to actually fill out the forms. It is enormously difficult. These are not individuals who are used to doing this kind of thing. And I think in addition to educating people about the vaccine, really getting on the ground help for individuals to really cut through this red tape and bureaucracy to be able to actually get the vaccine. And so in my mind, it's not only the site of vaccination, but who's going to hold individuals' hands and be there for them in their communities to really support their ability to make even that first step, to register for the alerts, and then ultimately to register to get that appointment. And then who's going to help transport them to that appointment? So at Dollar General, and in traveling the United States, there are a lot of dollar stores. I couldn't agree with you more. And they're in small towns. And this is what I've worried about a lot. They're in small towns where there aren't pharmacies. They're in small towns where there aren't big box stores. They're in small towns where the community could get together to really support the elderly and then support the next group and the next group and the comorbidities group to really ensure people are immunized. So I think Dollar Generals function more as a hub of the community than we're giving them credit for. And I think figuring out how we best utilize them, I think Dr. Clay Marsh is correct. You know, we don't want anyone anaphylaxing in a Dollar General store. And not that that's a rare event, but, you know, you don't want that to happen in any community. So you'd have to have a lot of EMT support. But I think figuring out how to support the community and really have a really service back to the community to ensure that people can wade through this very difficult IT space in order to be able to be vaccinated.
Right. And thank you very much. And so one of the things we had I said in my email and I wanted to talk to you about today is that we want to be able to provide some recommendations. I don't know what the future of the Warp Speed Task Force is. I'm imagining today was the debrief.
This was our last task force meeting. We've been meeting with the transition teams all along, and that's been a great privilege. So I think I want to just point out also, I mean, the current vaccine, Dr. Marsh is right. In a place like West Virginia, the problem is the number of vaccine doses being made available to West Virginia, and states that could do more, like West Virginia, North Dakota, South Dakota, that are over 77%, twice the national average of immunization, and have figured this out, should not be penalized and held back by states that are not moving as fast. But when you talk about Dollar General stores, it's also, and I appreciate you talking about advocacy and information to the community. I mean, right now, South Carolina and Alabama are sitting at about 2.3 to 2.4% of the adult population immunized. So about a third of what West Virginia has done. Figuring out how to admit that it's not working, and then your creative ideas about how to augment and make it work in different areas will be really key. I think everything should be on the table right now, because we have to admit to ourselves that the current situation, which we have the habit of doing in America, you can't make things super complicated during a pandemic. And sometimes the perfect is truly the enemy of the good. And right now we should be looking at places that have been efficient and effective because they figured out how to be in the community of the community and a partnership to the community to ensure people can get immunized. And we need to take your innovations that you're figuring out and get it to states that are having more difficulty, because I know solutions are out there. And I think what you all could do, and I think people are not doing this right now. And so, Toni, this is really important. You could catalog the solutions that are working in rural areas. So both adding your recommendations, but also cataloging what is already working to really show that this can be done, and it's being done in certain pockets of the United States.
Yeah, so thank you very much. And one of the things, like I said, I had mentioned in our email is that, I'm out here in rural West Virginia. I don't know anybody. So if we could send our recommendations to you, and maybe you could help us find somebody on well, I guess as of tomorrow, will no longer be the transition team, but in the new administration, about who we should talk to about these issues. So if you will, I guess what's the word I'm looking for? If you'll indulge me and say, yes, Toni, I'm going to take all of the recommendations from this group. So you'll know, there are over 100 people on this call.
Yeah.
We have Dr. Marsh, who is at WVU, who you know. We have Dr. Blanton Tolbert from Case Western. We have Dena Gray, who's from Beaumont, Texas. And they're having challenges with actually establishing their hub and rollout. But our ultimate goal here is really in the next few minutes to start talking about some recommendations about vaccine preparedness. What do we need to do to get these communities educated? We'll write up our Dollar General idea. I mean, Dollar General has their whole goal is that you should be in your car 5 to 10 minutes and you're at a Dollar General, right? That's their model. Their model is where's a food desert, and they want you also to be closer to them than you are to a Walmart. The only thing they don't offer is fresh fruits and vegetables, which is another thing I think we could probably talk to Dollar General about, but I won't go into that. So I'm looking at a couple of people, Dr. Birx. I was going to call you Debbie, and then I stopped myself. Dr. Birx. And so first question is, can we send you some recommendations? I know the task force is ended, but maybe you know who we can talk to on the Biden side of the house. Hello?
Thank you, Toni. I would be happy to get those. And if you send it to my Birx, BIRXDL@gmail, I will make sure that it gets into the hands of the individuals. And I think I hear you about vaccine preparedness. And I think along with that, getting people pre-registered. We all know what the questionnaires look like. Just like filling out your voting forms, we need people pre-registered with all of those pre-done, about allergies, about this, about comorbidities, everything just written out and available so that as soon as vaccine comes to that area that they can immediately, they get a text message or they get notified in some way that they are, they're up for evaluation. All of these things, I know there's creative solutions out there. And I think what we need is practical, on-the-ground solutions that will work for people, because sometimes we get things so complex that it's difficult for them to work for people.
Right. So I'm going to ask a couple of people if they have questions. Laura Jones. Laura Jones runs Health Right in Morgantown, West Virginia. And if I were 30 years younger, I would try to implement her model someplace in West Virginia and replicate it because it's the best thing since sliced bread. Laura Jones.
Yes. Do you have a question for me?
No, I'm asking you if you have a question
Oh, okay.
or a recommendation.
Well, I think I'm concerned. I like the idea of Dollar Generals being a hub for registering folks. And I think also in West Virginia, we could look at some locally owned pharmacies that also operate in rural areas. I happen to live in a fairly rural area outside of Morgantown, and we have our own little pharmacy. And then I think Dr. Birx and everyone has been correct that the key to what's happened in West Virginia is that it's simple, even for the agencies that are collaborating. So we got a call from the state at our clinic, and basically the call was, are you willing to do community-wide testing, COVID testing, in order to get COVID testing to vulnerable populations, which are the people that we see on a regular basis. We got the call. The next day, the paperwork arrived from the state, filled out the paperwork, sent in all the documentation. We got hooked up with a lab through the state, and the next week, the next Tuesday, we were doing community-wide COVID testing. It was that simple. We also have the same kind of registry set up for being able to provide the vaccine. So I've already filled out all that information in a survey document, and I'm just waiting to hear what action they want us to take next. So that's how simple it's been. And I think that's really the key to what is making West Virginia a success. And I have to say, that's not typically how things go at our state level. Apologies to anyone who might work for the state. So we've been able to kind of override all that red tape and get right to doing what we need to do to protect people.
So I'm gonna synthesize your recommendation, which you didn't really frame in a recommendation. But recommendation one is to make sure we keep things simple, right?
Yeah, even for the collaborators.
With your collaborators. Number two is I heard keep it simple, and I heard maybe even use existing providers that have community access, that have access to communities.
Absolutely.
So identify those. And I come back to Dena down in Beaumont, Texas, because there's two things. One, what recommendations would you have, or do you have, for this current stage that we're in, but also for the future? And I also do want to make sure that we keep coming back to the preparedness question. What do we need to do to educate people about this vaccine?
I think one of the steps is the definite inclusion of public health entities as a foundation for planning. I think that that's just critical, whether you're doing it, from our county standpoint or from a collaboration with other surrounding counties, like we work out here. So I think that collaboration is one. I'll be honest, one of the options we have that we're looking at is the support of other private institutions like foundations, and looking at how they can assist with some of the, those costs or those experiences, those resources that we don't think of. I understand that, and we haven't started doing the vaccine yet, but I understand that the data has to be entered twice, one into M-Track and one into something else. Nobody has two sets of staff to do that like that. So how do we, how do we plug up some of the holes as we go along in planning? I think having a standardized registration, but I love on the Dollar General, and Amber was just reminding us when we did HIV registration and testing at Boost Mobiles back in the day. So that idea definitely resonated, and I think it has life with university, with med students, like Dr. Marsh was saying, with his medical students and involving them in that process. I think that's a great way to incorporate students who are looking for clinicals and looking for replacement activity for their own education. And I think FQHCs serve a good place for them to be able to get some of that support as well. So uniformity, communication, I don't know messaging. I'm still in anti-vax land, anti-mask world. So messaging is a challenge. And then diversity of messages, because what is said in one part of a rural community is not the same that you say in another part. Rural doesn't just mean, it's not as homogenous as we think it is. So those are my thoughts.
And what I saw on Frontline was like the 6,400 we did in Houston this week and about 36 last week, is I saw young family members accompanying seniors to get the vaccine. The young person was not even interested. That was not their goal. And I saw we had like hundreds of wheelchairs. So I think to link, to accompany a senior in the process from beginning to end. And what I gave my mother was the end date at the 14 days after her second injection, what she could exhale. So to paint the picture of the timeline it takes to get to the 95% coverage that we're trying to get for the seniors is to help me schedule myself to accompany. We used to accompany full-blown friends to appointments, but we had a calendar when I could take off, when I could get them there because they could not get there alone. And I generally filled out all of the paperwork. So I saw family members and caregivers accompanying seniors. Yeah, they need a companion. They need someone linked to them to help get them to the end goal of the 14-day, the coverage after the second shot.
Bring your mama to vaccine day.
Yes.
Right. Okay. So I think we have another recommendation. So number one is buddy support, right? So it might be that I'm not necessarily registering for me, but I might be registering for my mom. But then I still have to do the other piece to get you vaccinated too. And so I think that we have to think about how we integrate that. And so, Dr. Birx, again, earlier we talked about the fact that most of many rural communities, not most, but many rural communities and southern communities right now are in the midst of syndemics, right? HIV, hepatitis, overdose from substance use disorder, and now they've got COVID on top of it. And so we're gonna I'm gonna ask Rustin if he's still there. Rustin runs one of the medically assisted treatment and recovery programs in West Virginia, because that's my other thought. My other thought is places like MAT facilities could be our partners in also doing vaccinations. So Rustin, are you still there? He probably is, and he's like, I'm not answering her. So, Dr. Birx, can you tell us anything that you in your travels that you've seen around how to roll out with substance use disorder facilities or substance use providers? Because a lot of the folks on the call do have a background in HIV and some in substance use disorder.
So thank you, Toni. I think, what has worried me about this entire pandemic is we weren't able to bring our community advocates to the table in the same way that we were able to do it with HIV and really get joint planning on the ground about how to best implement these. And I think figuring out if your Ryan White planning committee or one of your others can create this broader committee to really make recommendations from the county level up is really going to be key, because I really worry still that we're right now, if I had my way, we would be in churches with flip charts showing how these vaccines actually work and why it's important that people get it and why it's important that young people get it after we get those that are most at risk for serious disease immunized. To really get the information out, and you were absolutely right, the one who talked about different mitigation at different levels. I find a lot of rural communities, although very diverse, share this concept that these kind of bad diseases are in cities. And I think that made vulnerable communities, rural communities particularly vulnerable because somehow they believe that they were naturally spaced out. But rural communities have a much greater sense of community. And so they get together after church without mask on. They get together with their broader family. And I think using the church as a communication point, as well as all of our community advocacy and peer-led service delivery, is going to be absolutely key. Because I worry that every day that goes by, more people slip through the cracks, and we're leaving more and more people behind. And although that was always our mission in HIV, I feel like we haven't tackled this particular pandemic with that kind of really grounding in community. It's part of the reason why I went on the road, was to really hear from communities directly about what their needs were, so that we were really addressing these structural barriers. And so I think a lot more needs to be done with the advocacy groups to get out clear information, but also in through the churches, and potentially even having, flyers that really tell people how they can work and get these things. I just feel like your ideas about vaccine preparedness down to the local level are just essential.
Thanks. And so I really do want other people to put out what they believe their recommendations are. And I'm gonna definitely send them to Dr. Birx. And I'm going to hope we can find someone within the incoming administration that will also take on this charge of both preparedness, but also access and utilization in rural communities. What would your recommendation be, Clay? I mean, you're doing good, but how can you do one better?
Dollar General stores? No, I mean, I think that people have really discussed it. I think that they're, the real challenge, I think, when you have something this big and this unusual, the pandemic, it's been going on for so long, I think that we lose our resilience and we get much more fragile and much more inflexible. I think moving with agility and not being afraid to do things and then learn from them and continue to iterate is really important. We have this like a military operation. I mean, the National Guard and our smart people around the state help organize this. We have a joint interagency task force. We have a joint interagency communication group as well. So we are also aligned on our messaging, and we have we have people from the university. We've created a whole sort of supply chain so that we're self-sufficient. We have a social media behavioral media specialist that gives us insight about what people want to hear, how they want to hear it, how we say things. We get notes for every presser that we do about, don't say, I want people to take the vaccine, say, we hope that people choose to take the vaccine, which is a subtle difference, but one that has real important impact related to the experts. So, it's embedding the experts, letting people run with the stuff that they're really good at. We let the organizations, the associations help guide us. The reason why we got the nursing home people immunized so quickly is because Marty Wright, who runs the Nursing Home Association, and all of the people in the nursing homes, we had weekly calls with them, and we just turned it over to them or the Joint Interagency Task Force and said, tell us how you can immunize all your people and what do you need. And so it just works like magic when everybody is part of a team and you're really relying on the expertise of each other, the wisdom of crowds versus one group or one person trying to push everything. So I think this is really just a learning environment, scramble golf. And the key is we just want to all be hitting at the same hole. And if you do that well and you're not afraid to take a shot, then great things happen, and more people feel like they can contribute, which makes people feel a part of something bigger. And I think that that's really important too. Dr. Birx, I wanted to ask you for 1 second to comment on the importance of age as a target for vaccination. You've really been a champion for that. And I tried to discuss some of the priority, the reason why we chose age, and you were really a big part of that.
Well, thank you. You know, it's a privilege to look at the data every day, and also incredibly discouraging. So we have made great progress together in saving people's lives, but I know everybody on the phone knows that if you have a loved one who's over 70 and they get COVID, 20% of them are admitted to a hospital. And of that, not of that number, but of the all over 70 who get COVID, the fatality rate is still 10%. 1 in 10 over 70 who gets COVID. And so that is the most dramatic and highest, what we call case fatality rate that we have among any age groups. And so that's why the decision to immunize over 65 is so crucial, because those individuals are the most likely to get severe disease and the most likely to succumb to the virus. I think immunizing in the nursing homes is great, but let's remember that that's only 3 million of our individuals that are over 70. The majority of individuals over 70 are in multi-generational houses, like you just described, of people coming forward to be immunized and they're got their grandchild with them, or their niece or nephew, or their son or daughter. We have most elderly Americans live in the community. And I think that's why there has to be a community solution. I am thrilled that we're getting nursing homes immunized, but for every person in the nursing home, there's at least 10 to 20 that are outside of a nursing home and that need to be immunized. And maybe the community, which is why I keep pushing it to the community for this advocacy, they know who is most vulnerable, that is more shut in or needs transportation or is not very IT literate on how to really register for these vaccines. And that's why getting it to communities that know where those individuals live. This may take that kind of direct hand-holding, and I appreciate everything that West Virginia has done to really mobilize and have people understand that this is a remarkably deadly disease for people over 70. And we're still losing. It was 30%. So I'm grateful it's down to 10%. But losing 10% of Americans over 70, I just don't find at all something that any of us could live with. And I think the sooner we can get these individuals immunized, the better we will be as a country in understanding our respect and the dignity that we want to bring to our elderly.
And if I could just say one thing, Toni. So we have 240,000 people in West Virginia over 70 years old. And as we look at the number of people we vaccinated, and this is over 75, we vaccinated about 37,000 West Virginians so far. But you think about the Delta there and what Dr. Birx just said, I mean, a shot in the arm of these people, maybe even one shot in the arm of these people can save a life and can also reduce hospitalizations, which is something else this group does at a much higher frequency, which causes surge on our hospitals, which drives mortality rates in many other diseases, not COVID only, up in the hospitalized population. So I think that this is a critical point that many people, I don't think, realize as well as Dr. Birx just explained it.
All right. Thank you, sir. So I have a couple of things. Rustin, I was looking for you. I figured you were dodging me, man. So Dr. Birx, one of my big questions and one of my big goals is how do we also integrate MAT facilities and the recovery community into our response for both vaccine preparedness, and I keep coming back to it and I'll say it till I'm blue in the face, and with vaccination. I think that MAT spots are an ideal location for vaccination, particularly of high-risk people that have a history of substance use disorder. Rustin, what are your thoughts?
Yeah, our county, actually has little sites set up we really would prefer to have the vaccines just delivered to the county where people are used to trafficking and being there. It seems like there's been a call now to only have larger events in other venues, even outside of our county. And our people who were kind of excited about our success now are kind of wondering, well, why did all that change? I'm not sure what the right answer is, Dr. Marsh, but.
What's your count? Rustin, what county are you in?
We're in Barber County. And again, if there is infrastructure in a place to deliver on this, where people are used to going and seeing those people, that seems to make more sense to the people I'm listening to and even myself.
And maybe I could just respond very briefly, because we do recognize that benefit. The issue for us right now is we just don't have enough vaccines. I mean, we had to take a break to immunize our teachers because we wanted to send our students, our K through 8th grade, back to school. And so we just vaccinated in the last 2 weeks about 20,000 teachers that were over 50 years old. So ultimately, when we start to move in this way, it starts to, to take away vaccine to be able to distribute more broadly. So that's the reason why we're really desperate to get more vaccine if we can.
That makes sense.
Thanks. So Dr. Birx, if you could respond a bit to the substance use disorder question. And we've also got a question about when are other products coming online? The J&J, the AstraZeneca product, and somebody else. There's 3 of them, I think, coming out soon.
Yeah, I mean, those are very good questions. I think I'm just going to be frank because I don't know another way to be. When these first 2 vaccines showed this level of efficacy, to have a 94 to 95% efficacious vaccine and nearly 100% of prevention of any kind of severe disease is really extraordinary. So I worry about these, what we call the adenovector vaccines, both the J&J vaccine and the AstraZeneca vaccine, what we're asking them to perform at an extraordinarily high level. And so I think we have to be prepared that there may be that we have to utilize these 95% efficacious vaccines that protect against severe illness in our particularly vulnerable, our comorbidities, our elderly, and then utilize J&J. And I haven't seen the numbers. The numbers will probably go to the FDA towards the end of the month or the beginning of February for the J&J vaccine. I think then we have to really be strategic about how it's utilized. It may be more effective in younger people. I'm just hypothesizing. I have no data, 0 data. But I think we ought to be thinking about if it's less than 95, let's say it's 90 or 85, do we tier that vaccines that we know prevent severe disease at nearly the 100% level to those most likely to have severe disease, and then start using the other vaccines to actually induce what we call herd immunity and protect all Americans from COVID virus. Now, the last set of vaccines that are under development are what we call subunit vaccines. And the reason those are particularly important is the first 4 vaccines that we just talked about, the 2 that are approved that are messenger RNA that are better than 94, 95% efficacious, and the adenovirus vector vaccines, the AstraZeneca and the J&J vaccine. There's the subunit vaccines can be used to boost a waning immunity. So those are still under development and going into phase 3 trials. They're easier to make at high volumes, and easier to modify them and remake them at high volumes if what you've been hearing about variants, if there's drift and we need to boost against an additional immune response. And so it's not only the number of vaccines that we have, but the type of vaccines that we have that are really critical. And so I'm looking forward to these additional vaccine candidates coming forward, but I think we have to be mentally prepared about thinking about vaccines differently if there's differential ability to actually prevent severe disease. And for the substance use and substance use piece, I think that's really important. I don't know the age piece, but certainly there may be a significant increase in vulnerability, and certainly all of those sites ought to be vaccine preparedness and registration sites for referral for vaccination as the vaccines roll forward.
Thanks. And so, so you'll know, I don't know if I said it earlier, but we have Dr. Blanton Tolbert of Case Western, and he earlier today explained to us all about mRNA vaccine development. And he explained to us that the technology isn't a 5G chip going into anybody. So the way you framed it was really kind of played well to how Dr. Tolbert explained to us mRNA vaccines, so or the development thereof. So,
Toni,
yes.
Toni, it's Stephanie Lancaster.
Hey, Stephanie.
I want to piggyback on your great idea about Dollar General and say
Stephanie,
that.
Before you go further, Stephanie, who are you? And tell the people who you are.
So I'm the Director of Community Health Solutions for Emergent Biosolutions. We're the company that manufactures and sells Narcan nasal spray, and I cover West Virginia, Ohio, and Indiana. So knowing that the pandemic has increased the opioid epidemic and the death rates in all three of my states are at record highs right now, I would love to see the state of Virginia, or possibly even the federal government, since we're thinking big and we've got Dr. Birx in our earshot, consider the idea of wherever we do set up these strategies for rural reaching for the vaccine, we would include that every person leave the vaccine location with a Narcan kit and a brief explanation on how to use it and why we're giving it to every person that we see, because we know that people are going to come across someone who needs opioid reversal with a naloxone kit more than they'll need hands-on CPR or any of the other life-saving things that we can do for people because we care. So I'd love the idea of, you know, if it's federal, state opioid response dollars kind of being pulled back up. But I had this idea, and I talked to my boss about Ohio, you know, the idea of you get the shot for you, but you take the kit for them. And who are them, and to just, again, the whole idea of normalizing that part of the conversation early on in this call about normalizing COVID. Like, it's so crazy that now we've added COVID, and COVID testing and being positive for COVID is now a shame and a stigma that people have and want to spend time and energy on. How did you get it? What did you do? Kind of things where it's like, wow, that's the wrong place to spend that energy. But I just love the idea of, if we really can come up with these very executable ways to touch everybody, you know, and the most vulnerable, and why don't we, if we develop that access, why don't we use it for all things that those people are vulnerable to?
Right. And thank you, Stephanie. I think that's a really good recommendation given the vulnerability of the population, right? And I think, again, I keep coming back to this as just to me as a factoid, right? Which is that we are in rural America. Many of them are red states. My job, my goal, my mission here is not to change your mind about anything other than 408,000 people are dead. I don't want you, your family, or your community to be one of another number. And that, if you know, the national AIDS strategy, and I always say this, and everybody on my team gets sick of hearing me say it, the national AIDS strategy says very clearly, none of us can do this alone. It will take the federal government, it will take academia, community-based organizations, philanthropy. It will take all of us to get this done. And my thing is that we have to get this done together. Dr. Marsh has said it. Dr. Birx has said it. Dena said it. Blanton, he didn't kind of say it. He gave us a football analogy. So I think it's only the people on his football team. But we can do this. We can do this. What we have to do is attack not the mind, but the heart of the individual. And I think that that's where the challenge lies. I'm not going to change your mind on your politics. I'm not going to change your mind on some of your other core values, but maybe I can attack your heart and say, you don't want your grandmama to die. You don't want your sister to die. You don't want your nephew to die. You don't want to die. So maybe you don't believe it's true. Maybe you still believe it's a hoax. But guess what? Whatever's killing people, let's figure out how we stop people from dying. Dr. Blanton, are you reaching for your mute button to say something?
So, I was going to have to get off the Zoom here momentarily, but I did want to just chime in on some of the comments that part of the discussion. This has been great, and thanks for again putting this together, Toni. I like this idea though of of making this really a grassroots effort to really get information out. And Toni, I think, knows a little bit of this about me. I'm really big on just basic scientific literacy, and I think in addition to Dr. Birx's comment about going into the churches, I also think just getting information out about the science behind the vaccine, the science behind viruses in our public schools as well, right? And let the kids go back home and tell their parents, tell their grandparents about these things. I also think can have a significant impact. So I just wanted to leave it with that as my addition to the last part of this conversation.
Thanks. Blanton, that model of teaching kids about smoking had a huge impact on the number of people who stopped smoking. It wasn't, they're educating the kids. Here's what this is doing to you and with secondhand smoke, but here's what's going on with your parents. And I'm an admitted recovering smoker. I smoked from the time I was 12 till I was 40 something. And one day I picked up my 5-year-old nephew who looked at me and said, Aunt Toni, do you know that you're turning your lungs brown? And I was like, what? He's like, yes, this is what happens to your lung when you smoke cigarettes. We learned this in school today. He said, and also it will affect your teeth and likely your heart, and you will have a stroke and die. Do you think you should continue to smoke? And he was very matter of fact about it. He was judgy as all get out, but very matter of fact about it. So I think that that's an absolute great idea and will be on our recommendations list. Let's see, anybody else have any recommendations that they want to make? It's never too late. We are going to send these recommendations and suggestions to Dr. Birx. And I'll get her email we have an email exchange and I'll get it there. I'm not giving it to all of you. No, you can't have it. So stop. So Dr. Birx, I just saved your life because they were all going to ask for your email address too.
She did say it. She did say it, right?
I know, but I know y'all didn't write it down fast enough. I know y'all didn't all write it down fast enough. So I'm going to save her by saying she doesn't need to repeat it again. But again, Dr. Birx, thank you for joining us. I know that the meeting came up for you. I really do appreciate the work that you've done for PEPFAR in the HIV community and the work that you've done on the task force. Blanton, I want to thank you. I really appreciate you. So proud of you with your new appointment at the Office on AIDS Research as the co-chair there. You do an amazing work there. Clay, you've become one of my new good buddies. I appreciate everything that you've done to roll out vaccine and HIV and COVID for West Virginia. I'm always here to help. Whatever you need from Community Education Group to help you with the rollout, and we'll see you at Dollar General near you. The last and final thing is that we're doing a survey on rural America needs around capacity building, COVID, substance use disorder, and a whole bunch. You will get a gift card. There's one gift card for $500. There's two $250 gift cards, and there's $500 gift cards. Complete your survey and you could win a gift card. Could be all yours. There's an organizational survey and an individual survey. If you run an organization and you keep the gift card, who am I to tell? So thank you all.
Tony.
Thank you very much. And we will be doing something like this again real soon.
Thank you.
Thank you,
Bye.
everybody.
Bye.
Bye.